Howdy, y'all. This is Dr. Jeff Jarvis, and I'm going to talk to y'all about some practice-altering papers, or at least potentially practice-altering papers. This is a lecture I gave at the Texas EMS conference in 2015, and it's something I do every year, and basically I just go through and find some papers from that year that I think have the potential to influence our practice, and that is either in a good way or a bad way. I was, oddly enough, at a bar, and I was discussing with some colleagues some of the papers I was going to pick, and some of their comments was, "Oh my God, you picked that turd? What are you possibly gonna? How can you possibly say that's one of the top papers?" So, well, it's not really a top papers; it's a potentially practice-altering paper, and this is sort of synonymous with when Time put Hitler or Osama bin Laden or Saddam Hussein on the cover as the Man of the Year. It doesn't necessarily mean you're there for a good reason. It could be that you're there because you're a nasty terrorist who wants to kill a lot of people, or it could be there that you are a misguided paper that has the potential to do a lot of harm to EMS practice but gets wide notoriety. So we're going to talk about some of those also. So let's go ahead and get started. The first paper is something on ketamine. So this is a nice little paper that talked about the experience that the Columbus Fire Department's EMS division had using ketamine. So this is a relatively small paper, and it's not a randomized controlled trial by any means, but it is a really interesting description of their experience. And the other nice thing about this is this does make a pretty good case for the use of ketamine. And specifically, they're talking about here for agitated, combative patients, patients with excited delirium. So the case they make is that for these patients, if you're doing physical restraint alone, that can be lethal. And it's lethal because of a combination of metabolic acidosis or rhabdomyolysis that can end up with hyperkalemia and ultimately cardiac arrest. Now, you see this on the newspaper all the time when it comes to death in custodies. We would all recognize that that's bad clearly for the patient, but it's also bad for the officers involved, it's bad for the departments, it's bad for the families, it's bad all the way around. So if there is some way that we can prevent this, if we can control the combative behavior, which clearly we have to do, it turns out if we can do that in a way that is clearly not lethal, we can really, everybody ends up benefiting from that. So if you can add in chemical restraint, appropriate chemical restraint, you can avoid all of those side effects. So if you're going to pick a drug, what kind of drug would you pick? Well, you would want it to have a rapid onset of action. You would want it to be able to be given IM. You don't want to be dinking around trying to start an IV on someone who's kicking your butt. You also want it to have a very wide therapeutic window. In other words, you don't want there to be a very narrow range of dosage that you can use. So if you use, say, 2 milligrams of a drug, it's effective, but 2.4 milligrams, it's lethal. That's a narrow therapeutic window, and we don't want that. You also want it to be very safe. If you do go over and give too much medicine, you want the consequences of that to be really pretty limited. So they talk about a couple of different agents. They talk about benzodiazepines. I think the majority of people are probably using benzodiazepines. And they work. The problem is you have to titrate the dose up to effect, and by the time you get to the effect you want, you're well into the dose range where you can get some pretty nasty side effects like respiratory depression. So there are some pretty bad side effects that can come from using benzos. Plus, the patient continues to be out of control, a risk to himself and a risk to all of us that are trying to take care of him. So benzos aren't probably the best drug. Droperidol is an awesome agent. There's actually a study called the DORM study that looked at droperidol versus benzos and showed that droperidol is a great drug. Now, that doesn't do any of us much good because we can't actually get droperidol. It's a damn shame, and I feel like having a moment of silence every day just to mourn the loss of droperidol. But the bottom line is we don't have it. Ketamine, on the other hand, is almost an ideal agent. It has a rapid onset. You can give it IM, you can give it IV, you can give it intranasally if you want to. It has a huge therapeutic window and is very safe. And the benefit of this agent is it can achieve control of the behavior and leave the airway reflexes intact. So all the way around, great drug. All right, so let's go back to the paper. What was the experience that Columbus Fire Department EMS had? Well, their indication, just to give you some background, is this was for combative patients only. The methodology of this chart, this paper was a retrospective chart review. It looked at papers from October of 2010 to October of 2012. The only people in the system that were carrying it were the supervisors, so you'd have multiple responses to these types of patients. They used pretty respectable doses. For IM doses, they did 4 milligrams per kilogram, which is a little less than we're using. We're at 5. And 5 has been reported in the literature to be pretty safe, but they've been doing this a while, and they picked 4. If they did happen to have an IV, they used 2 milligrams per kilogram. So that is well within the dissociative range. So their primary outcome was in an improved condition noted in the EPCR. So that's like when you have to choose from your pick list on what the effect of the drug was. They were looking for improved. They were also looking in a secondary outcome for whether intubation was applied, whether you had to be intubated in the field or in the ED, or whether you had to give additional sedation. So this was not a huge study. They had ended up giving it 36 times, and they saw improvement in 91% of the patients. They needed additional sedation, in which case that was benzodiazepines, in 17% of the patients post-ketamine, both in the hospital and in the ED. So let me do some rapid math there, in 83% of the patients, they did not have to give any additional sedation. So that looks like it's pretty effective. The other nice thing is that there was no subsequent taser use after ketamine was used. So this is a big problem for us. We realize that tasers are not lethal, but if we can avoid using them, we're going to be better off because we can get the effect we're looking at without having to use some sort of compliance weapon, particularly that doesn't look good if somebody's sitting there with their iPhone in your face. So the medicines are much better off. The big thing this paper found, though, that was a little surprising was 23% of patients who got ketamine were intubated either in the field or the emergency department. So that seems like a really, really high percentage, particularly for a drug that leaves the airway reflexes intact. Now, we do know that there is a small subset of patients who get ketamine, particularly rapid IV ketamine, that can have some laryngospasm. Now, the key to dealing with the laryngospasm is just to slowly bag the patient through it, and within a minute or so, you'll be fine. So really, 23% of patients getting ketamine that ended up being intubated was quite the shock. But then in the paper, they actually go through and they describe those 23% of patients. And it turns out that those were 8 patients. Now, one of them was intubated in the field. And if you actually look at the indication for giving ketamine, it was to promote and facilitate intubation. And the underlying nature of the call was not a combative patient, it was a cardiac arrest. So the paper describes it. Basically, they had a patient who was in cardiac arrest, but they seemed to have had pretty good perfusion. There was some trismus. They had a difficult time opening the airway. So they gave ketamine to try to facilitate that. I don't think that's really a knock against ketamine. There were some additional, 2 additional patients that also got large amounts of benzos before the ketamine and some getting it after the ketamine. So and we know that benzos, particularly in large doses, can lead to intubation. So it's a little fuzzy there. We also saw a patient who ended up having a head bleed and was combative because of that. They didn't need any further sedation, but they did get intubated in the ED. So it's not real clear whether the intubation was because of the underlying pathology or because of the ketamine. And then finally, and this is the one I feel is particularly interesting, and I think it's relevant because we see things like this also. This patient was combative. He had been drinking, it turns out, after the fact. And so they whacked him with ketamine, knocked him down. Everything looks great in the field. They go into the ER. They tell the ER doc, hey, it's a combative patient, got ketamine. He's under control now. And the ER doc immediately intubates him, and his diagnosis is ketamine overdose. So when I read that, now clearly I wasn't there, and I don't know what happened, but when I read that, what I get is an ER doctor who's not comfortable with the use of ketamine and is blaming something on ketamine that may or may not be its fault. So there we have it. It's a small paper, but it does give some real-world experience with what people are seeing with ketamine. In this particular paper, the thing to be aware of is somebody may say, well, wow, we can't use ketamine because it had an unacceptably high percentage of patients being intubated. And we really have to be prepared to push back against that a little bit because it's not clear that the ketamine was really the issue at hand. All right, so paper number 2. This is the effects of ice slurry ingestion before exertion in wildland fighting gear. This is kind of a great concept. A lot of y'all know that I do endurance running. I'll go run for hours at a time. So I keep up with some of the athletic literature. And this concept of drinking an ice slurry to try and hold your core temperature down has been around for a while in endurance running and endurance cycling. And as a matter of fact, some of the things they found with cyclists is particularly interesting because not only can you look at endurance and how long you can continue your exercise and how long you can do it at certain heart rates, but you can actually measure power output. So when they did this with cyclists, what they found is drinking an iced slurry. So they're drinking, it's a cup full of essentially like a Slurpee. They'll drink that, and they do it 30 minutes prior to their exertion, and then they go forth and do the exertion. The cyclist could go longer. They could do it at lower heart rates with lower core temperatures and actually put out more power. So in the athletic world, this looks like a pretty neat thing. These authors wanted to see if that was equally true in firefighters who are doing not structure firefighting, but wildland fighting. And the idea, the reason this is important, theoretically anyway, more important with wildland firefighting than structural firefighting, is in wildland firefighting, you're out with an isolated crew, and it is much more difficult to take periodic breaks. So you can't come out every time your SCBA goes dry and take a 10 to 20 minute break. One, they don't have SCBAs, but two, there's just no place to go. So it's a little more important for these folks. So what did they find? They found that the bottom line on this is if you drink that ice slurry 30 minutes prior to exertion as compared to drinking just a controlled beverage, which is at 20 degrees Celsius. And again, the ice slurry is at 0.1 degrees Celsius, or is close to just slightly above freezing. They would put you through the United States Forest Service. They have this test that they run where you get all your gear on and you get on a treadmill and you go to town and they see how long you can go. This test did that, but they also made them swallow a little bitty pill that would transmit their core body temperature to an external receiver. And what they found was that you had a lower core temperature, you had lower perceived exertion, and a lower heart rate. However, the perceived exertion and heart rate were not significantly less than the control beverage. The core temperature was significantly less for the first 30 minutes. After 30 minutes, the effect is gone. And that kind of makes sense. We know that this isn't something that's going to last forever. But it's a neat concept, and it is probably something that we should be thinking about with our structural firefighting colleagues. They do have the opportunity to come out, and during the rehab, as we're having them drink, perhaps we can have them drink this slurry beverage and allow them to maintain that benefit. All right, so next up is parenteral midazolam is superior to diazepam for the treatment of pre-hospital seizures. Now this paper I really like for a couple of reasons. One, it says something that I agree with, which is that Versed beats Valium. And it is just the methodology of this paper I really like because it's a nice way of giving the finger to all of these drug shortages. This paper was done up in the Buffalo, New York area, and they had a large system there. And have a large system. They had problems getting both Versed and Valium because of these drug shortages. So as a result of that, what they had was some vehicles, some of their crews were using Versed to control seizures, and some were using Valium. And each of those crews would be using a different drug at a different time. So there was a nice, almost natural randomization that came from this. So it was a great opportunity to get some good information out of a really crappy situation. So let's go over this. They did this study from January of 2011 to May of 2013, and really what they were looking for was Versed compared with Valium. Now the dosing they used was, with one exception, relatively reasonable. The Valium was 5 milligrams, whether they were giving it IV or IM. The Versed had a decent IM dose, 5 milligrams. Now that's less than what we look at. And we know in the Rampart trial, they looked at 10 milligrams of IM Versed versus 4 milligrams of IV Ativan and saw that those were equivalent, but they did see that 10 milligrams IM was effective and safe, and that's the dose that we're using. So they used half of that. They used 5 milligrams of IM Versed, but only 2.5 milligrams of IV Versed. So even with that, if you think about that, they're underdosing the Versed just a little bit, and comparing it with what is a pretty standard dose of Valium, and even with that, the Versed was superior. So what were they looking at? Their primary outcome was, boy, this is hard to say too, seizure cessation. So did the seizure stop with no further seizures after the first dose of drug only? So one drug, one dose only, seizure stops, no further seizures. That's what they were looking for. So they gave this to 440 patients. And as all papers will do, they looked at what the characteristics were between those groups, and they were equivalent populations, or as equivalent as you can get without randomization. And then they looked at all of the different combinations or comparisons you could come up with. So for example, they looked at IM Valium versus IM Versed, and in that, the IM Versed was significantly better. They looked at IM Valium versus IV Valium, and in that case, the IV Valium was significantly better. They looked at IM Valium versus IV Versed, and there was no doubt about that. The IV Versed was much better. They actually looked at IM Versed versus IV Valium, and that was non-significantly, that was the same. So even if you have an IV in place, IM Versed works as well. So that's nice, and that's kind of the same thing we were seeing with the Rampart trial. So IM Versed beat IM Valium, IV Valium beat IM Valium, and IV Versed beat IM Valium. And those were significant differences. All the other combinations were non-significant. Now, some other interesting data you get out of it, if you again are looking at the first dose success without any further seizures, without any further drugs, overall, Versed, regardless of the way you gave it, stopped seizures 65% of the time, whereas Valium stopped it only 49% of the time. So if you're using Valium to control seizures, what this paper suggests, as does some other literature, is that Valium is not as effective as Versed. All right, so let's move on to the next paper. This is number 4, and this is something that I think is really interesting. It's the utility of pre-hospital ECG transmission in a large EMS system. And when they said large EMS system, they are not joking. This is the LA County system, and it is a truly massive system. Just in that county, they have 34 designated STEMI receiving centers. They have a ton of different EMS agencies, and they do collectively truly a massive amount of 12 leads. They run over 200,000 12 leads a year. So that's a lot. So what this paper was looking at is historically they had noted that they had a really high number of false positive activations. And they wanted to see if transmitting EKG would decrease those false positives. And their hypothesis is that it would. So to give you a little background on their system, the way this is working is, at least as the way this paper describes it, is that the indication for doing a 12 lead was wide open. So you could do a 12 lead on anybody you wanted. If the machine read star.star MI STEMI, then they would say that's a STEMI and they would transmit it. And they would transmit it. Their instructions were to do 100% transmission. So that's the background. The paramedics were not interpreting the 12 leads at all. Their opinion was not part of the decision to activate. The other thing to note that's different in this system than different in our system is that the paramedic didn't do the activation. What they would do is they would call the nurse at the ER. This is in California, and they have these mobile intensive care nurses, MICNs. And that nurse, either with or without consult with the ED physician, would decide whether or not to activate based on all of the information that they had. Now, theoretically, that information included the 12-lead ECG. And I say theoretically because it's really interesting. They would transmit or try to transmit 100% of their ECGs, but really they only actually made it through a minority of the time. So 25% of the time that they transmitted it, was the ECG actually received? So in the rest of the time, so 72% of the time they tried to transmit it, it just went off into the ether somewhere and they weren't able to. Now this is in Los Angeles County, and even though I don't live in Los Angeles, my perception is that that is a pretty dense cell phone covered area. I would imagine that there would be quite a bit of coverage, so that shouldn't be the issue. You would think, hey, the technology is easy. I can send something on my iPhone and it just goes through and works. Well, it turns out that it doesn't just work. Only 28% of the time did it work. So there's a real technological problem with the transmission of 12 leads that I think is dramatically underappreciated. All right, so the other issue on false positive activations is you have to define what a true positive activation is. Now, they used a metric that was easy to use, but I'm not sure that I really agree with. But for the purposes of this paper, it's all right. They said a true positive is somebody who went to PCI or was emergently referred for cabbage. The reason I think that is not a great mechanism is sometimes you have a patient who's clearly having a STEMI, who clearly meets the criteria for pre-hospital activation, but when they get to the emergency department, it turns out that there are some extenuating circumstances. The patient has a DNR, they're elderly, and they have some comorbid conditions. For example, they're septic or whatever the issue is. Maybe they just don't want it. Those patients then who were clearly having STEMIs and clearly met the criteria for pre-hospital activation would appropriately not go to the cath lab for good clinical reasons, but they would be counted as false activations. So just as an aside, that's the reason I have a problem with that definition. But as you'll see, the numbers in this paper, it doesn't matter. They were so far off, it doesn't matter. So when I say they're so far off, what kind of things did they see? Well, first off, this ran from April 2011 to September of 2013. During that period, they had 7,768 STEMIs going to those 34 receiving centers. So a little under 8,000 STEMIs. All of those they tried to transmit. 2,100 of them actually made it through. 4,300 of them did not. And then the difference, they just never looked. They couldn't figure out whether it was actually sent or not based on the EPCR. Now, of those, 73% of the, well, let me do this a different way. Of the 74% that were not transmitted, 55% that were not received, 74% of those had an activation. So if you call in and say, hey, the machine says it's a STEMI, you try to send it and the ER doesn't get it. So that's 55%. In that group, they activated 74% of the time. So even though they couldn't see the EKG, they said, well, look, if you say it's a STEMI, we'll activate. Well, they wanted to see what was that compared to the group where the ECG did go through. And in that group, they activated 73% of the time. And obviously, that's not a statistical difference. So what they're thinking here is that regardless, if the ER doc, whether they see it or not, is just going to say, if the medic says it's a STEMI, light them up. All right, so the whole reason they did this was to decrease false positive activations. Did it make a difference? Well, in the group where an ECG was not transmitted, there was 61% of those activations were false positive. So a 61% false positive rate. That was slightly decreased with ECG transmission down to 55%. So that's a relative risk reduction of 6%. So overall, they can decrease false positive activations, but by a small number. So I did a little bit of math, and what I came up with is they said out of the almost 8,000 STEMI activations, they could decrease 108 unnecessary ones. So that comes out to be 1.8% of all field activations they could decrease. They could prevent that false activation. Now, 1.8% when you're running at best a 55% overcall rate is not going to make much of a difference. And there is a real opportunity cost to using pre-hospital transmission. You have to write a really big check for a system this size to afford pre-hospital transmission. And if you're not going to get a pretty good sized bang for your buck, then you'd be much better off spending that money on something else. Now, my argument has always been that that something else should be teaching your paramedics how to read 12 leads. And it turns out that the authors of this paper actually agree with that. And they said, this is not a sustainable practice. What we need to do is teach the paramedics how to interpret the EKG, how to interpret the clinical picture, and use all of the information at their disposal, both the computer interpretation, the paramedic interpretation, and the clinical picture, to make the decision to activate. One other thing I want to talk about. Why are their rates so incredibly high? Well, I would argue one is that they're not teaching their paramedics how to interpret the EKG, but the other is that there is a prevalence issue. So if you are doing 12 leads on just about everybody, so if you have a sprained ankle, you get a 12 lead. And I don't have a problem with that, by the way, knock yourself out. The problem is that when you don't take into consideration the clinical context of the EKG, you can have an EKG that barely meets the STEMI criteria. The machine will read it, the paramedic will read it, but the paramedic will also be looking at the patient and they'll know why they got it. Crushing substernal chest pain with an iffy EKG, okay, that makes sense, call it. An iffy EKG with an ankle sprain that you got a 12 lead just because you're trying to teach your paramedic student how to do 12 leads, that's not a STEMI. The paramedic can make that determination, the machine can't. So that's the information out of this paper that I think is particularly relevant. Next up, getting to intubation. This is a comparison of invasive airway management and rates of pneumonia in pre-hospital and hospital settings. So this is kind of a neat paper. This is a reanalysis of the ROC hypertonic saline study. So as you know, the ROC study, or the Research Outcome Consortium, is a large group that does really high stakes research in the field and does it in a really good way. This hypertonic saline study was a randomized controlled trial. They were using 10 sites with 89 agencies, over 7,000 EMS providers, and 32 hospitals. They were collecting data from May of 2006 to May of 2009. And particularly with that, the initial outcome on this was they wanted to see whether hypertonic saline in patients with traumatic brain injuries or low systolic blood pressures did the hypertonic saline make a difference? This paper, on the other hand, took that data and did a reanalysis of it. And what they found was 2,222 patients, and they wanted to see whether the act of getting some form of invasive airway, meaning a supraglottic or intubation or a cricothyrotomy, in the field increased the risk of getting pneumonia in the hospital. Now, they also looked at it to say, well, what if you got that invasive airway in the hospital, in the emergency department, and then got pneumonia? What were the rates of that? And so it's a nice little thing. Their hypothesis here is that doing intubation in the field is inherently dirty and unsterile. Not that there's much sterile about an emergency airway, but they said it's inherently dirtier, and you're at more risk for aspiration, and therefore you're more likely to get more pneumonias. So they wanted to see. Now, they did exclude a couple of groups of people to make this a little cleaner paper. They excluded anyone who died within 24 hours. They also excluded anyone who didn't have any information about pneumonia. And they excluded patients who developed pneumonia within the first 2 to 4 days of hospitalization, with the idea that that was probably a pre-existing pneumonia. So they actually had some pretty specific criteria on pneumonia. They're looking for a bronchial alveolar lavage or a Gram stain. in addition to the normal definition, whatever the normal way of defining pneumonia is. So I typically define it, and most ER docs do because we don't have all the other stuff, is by clinical presentation and x-ray. All right, so what did they find? They ended up with 1,676 patients. 344 of those, or 21%, had no invasive airway. 786, or 47% of them, had some type of invasive airway. And then 498 had an ED invasive airway maneuver. And there was some overlap, by the way. So they put in a supraglottic in the field and then got intubated in the ER. But that was only, where they got both was only about 2%. Now what they looked at was pre-hospital invasive airway management versus ED invasive airway management versus nothing. And what they found was that pre-hospital intubation or pre-hospital invasive airway management had a significantly higher odds ratio of getting pneumonia than not having anything done. So if you didn't have your airway manipulated at all, either in the field or in the ED, then you had a lower risk of pneumonia. So the risk of pneumonia with a pre-hospital manipulation, the risk ratio, or odds ratio, I should say, was 6.8. If you had it done in the ED, it was 4.8 versus 0, which was the baseline measurement of nobody mucked with your airway at all. Now, if you look at, so pre-hospital airway had the highest rate of pneumonia, ED was second, and what they found was, and actually, oddly enough, in that small group of patients that had both, their rate was even lower. So their odds ratio was 2.3 for having it done in both places, which I'm not quite sure what to make of. That doesn't make a whole lot of sense. Bottom line is pre-hospital airway or ED airway increased the risks of getting a pneumonia, but pre-hospital was not statistically worse than ED. So what we found from this is that it's not really where the airway is done, it's just that you have to do the airway. So that was their conclusion. Any airway manipulation increases the risk of pneumonia. Now, some subsequent secondary outcomes, they wanted to see whether there's a difference in length of stay and length of stay in the ICU, and there was not. No difference. So, and they did try to do some statistical manipulation to control for different severity. You can imagine that the patients who get intubated are, there's a reason they got intubated. Perhaps they're more sick than the patients who did not get intubated. So bottom line, getting your airway manipulated increases the risk of pneumonia, but where you get it manipulated does not have a statistical difference. All right, next up. This is Mike Levy's paper. He's the medical director up in Anchorage, Alaska. And this is a quality improvement initiative to optimize the use of a mechanical chest compression device within a high-performance CPR approach to out-of-hospital cardiac arrest resuscitation. So I'm just going to kind of give you the big picture of this. Anchorage Fire Department uses the Lucas device. When they first, before they rolled out the Lucas device, they had a really well-tuned pit crew CPR approach to doing CPR. So they had really worked on minimizing compression, or minimizing interruptions to compressions, I should say, and swapping out. So they would do the classic version of pit crew CPR. They're doing 2 cycles. You do 100 compressions. You rapidly swap over to a new compressor. Every 200 compressions, you stop for your pulse check. Their initial protocol when the Lucases came out was get the Lucas on as soon as possible. They didn't really provide a whole lot of instruction on how to do that. What they found during their review of their CPR is that they were having a lot of pauses to put the Lucas on. So then they came up with a new protocol. And the new protocol is essentially that you do 2 cycles or 4 minutes of minimally interrupted chest compressions, or MICR, cardiocerebral resuscitation, basically what is going on in the Arizona plan that Dr. Bogor talks about. So 4 minutes of CPR, then they apply the Lucas, but they do it in a 2-step application process that is very choreographed. They first slide the board in at a previously scheduled pulse check, and then they do another 2 minutes, and then they, during that 2 minutes, they've attached 1 hinge of the Lucas, and at their next pulse check, they go ahead and drop it in place. So they did lots of training on this, lots of simulations, and then they looked at their interruptions before and after implementation of the new process. What they found is that before the new process, their interruptions in chest compressions that were needed to put the Lucas on were on average 21 seconds long. 21 seconds. After that, it dropped down to 7 seconds. So they really did fine-tune the application of Lucas. So it dropped from 21 to 7, which is clearly a statistically significant difference. They also looked at the percent of cases where their longest interruption was when the Lucas went on. Before implementation, 74% of the longest pauses were because of Lucas application. After the fact, 31% were due to that. The longest interruption in compressions before was 25, after was 13. Their compression fraction, so the percent of the time that you should be doing compressions that you are, went from 90% up to 95%, which was statistical. And then they also did this comparison about how long does it take to put the device on compared to your total no flow time, and that dropped also. So the bottom line, and they make this point very, very nicely, is that the application of the Lucas device is a team sport. It's not an individual effort. It's a team sport, much like CPR is, and you absolutely have to choreograph it, practice it, and know how you're going to implement it. The final thing in their discussion is they said, look, we know that interruptions, prolonged interruptions and compressions can increase mortality. We also know that without this two-phased approach, we had prolonged interruptions and compressions just to put this device on. And when you go back and look at the literature, there are two really nice studies, one called the Paramedic study and one called the Linked study, which looks at the use of Lucas and whether it improves outcomes or not. Both of those papers, as y'all probably know, failed to show an increase in survival based on the Lucas. Dr. Levy and his colleagues say, well, maybe the reason is that the Lucas is actually good and increases your compression fraction, but because you take so long to put it on, maybe that negates any potential benefit. So I think that's a great argument. I don't know if it's true or not, and they don't even try to say it's true in this paper, but it is a great argument. Now, the argument that I make is we're not using the Lucas device for a patient survival benefit. We're using the Lucas device for a paramedic survival benefit. For those few times where you actually have to transport a patient with CPR in progress, the Lucas device can save our lives. And that's the reason I'm a big believer in the Lucas. It's crew safety, and it's a resource multiplier. So we think that's a good thing. All right, next up, one of my favorite topics. This is delayed sequence intubation, a prospective observational study by Dr. Weingart. So this concept of delayed sequence intubation, where you are essentially doing a procedural sedation on a patient with the procedure being pre-oxygenation. This is a concept that's actually been around for a while, but Dr. Weingart, particularly through his MCRIT blog, has coined this term delayed sequence intubation as opposed to rapid sequence intubation, and is really pushing this out through social media and through the foamed world. And that's where I first found out about it. So it's a great concept. The idea here is bad things happen to people who are intubated when they are already hypoxic. They get much more hypoxic, they get bradycardic, and just badness ensues. We know that if you're looking at patients with traumatic brain injuries, one single episode of hypoxia doubles your mortality. We don't know what it does in other patients, in medical patients, but we can assume that it's not good. So the key to preventing those intra-intubation hypoxic episodes is adequate pre-oxygenation, denitrogenating the dead space, getting as much oxygen in there as possible. His point here is that there are some patients who are already combative because they're hypoxic. You can't get good pre-oxygenation just using a non-rebreather. So what they do is they give ketamine. That's the procedural sedation. The patient goes to sleep, but because ketamine leaves the airway reflexes intact, they're still breathing just fine. They will then apply some type of pre-oxygenation. The way I like best is they actually do CPAP or BiPAP with nasal cannula oxygenation. And what this paper, and then they'll go ahead, once they get 3 good minutes of pre-oxygenation, they give the paralytic an intubate as usual. And he does nasal oxygenation on all of his intubations. So what did they look at here? This was a a study done in 3 emergency departments, 1 Danish and 2 American studies. And they looked at the population of patients who failed 3 attempts at normal, standard, non-ketamine-induced pre-oxygenation. So there was something wrong with these folks, meaning that they're agitated or they couldn't tolerate BiPAP or the non-rebreather. They gave them 1 milligram per kilogram of ketamine and then titrated up in 0.5 milligram per kilogram increments until they reached full dissociation. And on average, that took 1.4 milligrams. Then they pre-oxygenated for 3 minutes, then added in the neuromuscular blocker and intubated. And their primary outcome is a change in the pre-DSI oxygen saturation to pre-intubation oxygen saturation. Now, that took me a while to understand. So the pre-DSI saturation is essentially as good as it was going to get without using ketamine. And in normal non-DSI circumstances, that means that's as high as you're going to get before intubating. And we know if that number is not above, say, 92, 93, their risk of desaturation, having a critical desaturation, is much higher. So that's what they're trying to avoid. So they looked at what the oxygen saturation was before DSI, and then what the oxygen saturation was after DSI facilitated pre-oxygenation. And the time they picked was right when you remove the pre-oxygenation device and shove the blade in. What they found on 62 patients is that the pre-DSI oxygen saturation was 89.9%. So in that group of patients, on average, they are already hypoxic when the intubation begins. The post-DSI, did it work? If this works, we would expect the saturation to be higher, and it was. It was 98.8%. So you can see that on average, your oxygen saturation went up by 9%, and it got you into a very comfortable and very safe place to do the intubation. So 32 of the 62, a little under 50%, had what would have been a high-risk oxygen saturation if they had not done the DSI. Of those, 100% had an increase in their pulse ox with DSI. 91% of them, of that high-risk population, got a saturation up above 93%. So using this process in this small study worked, and it worked very well. One additional thing they found is 2 of these patients were being intubated because of just really gnarly asthma. So they gave them the ketamine. Once they went to sleep, they were now able to tolerate BiPAP. They put them on the BiPAP. They improved to the point that they actually did not need to be intubated. And keep in mind that one of the reasons for this very well could have been the ketamine itself. Ketamine is a bronchodilator, and that could have facilitated the improvement. So they also looked at any side effects, and they didn't really see any side effects. There's no pre-paralysis apnea. Now, we expect apnea after they give the paralytic, but there was no apnea before giving that. There's no peri-intubation emesis or cardiac arrest or death. So those are all things that are good to avoid. All right, so next up, this is one of those turds in the punch bowl papers that I was talking about initially. So this is like Saddam Hussein on the cover of Time magazine. I don't necessarily agree with this paper. As a matter of fact, I don't agree with this paper at all. And I don't think it is a particularly well done paper for reasons that I'm going to explain. However, this paper, when it came out, it was published online November 24th. By the end, it got very, very, very rapid uptake in the popular literature. So New York Times, lots of agencies and lots of news media are talking about this. And as you can see from the title, outcomes after out-of-hospital cardiac arrest treated by basic versus advanced life support. And their conclusion, just cutting to the chase, is that patients who got BLS had higher survival than patients who got ALS. Therefore, ALS is killing people, and we really just need to get rid of ALS and use BLS only. Okay, so you can imagine if that's on the cover of Time, if that's on the cover of the New York Times, our policymakers may be coming to us and saying, hey, what's up with all this expensive ALS stuff? You actually get better results at a cheaper price if you just do BLS. Why don't you do that? These people said so. All right, so let's take a look at this paper. What are we actually seeing? So first off, this paper was done by a couple of economists and an internal medicine doctor at Harvard. And I don't want to, I'm not trying to disparage those credentials. And Harvard is obviously an outstanding medical school and they do some really good research. This just wasn't one of them. This, I think, is kind of classic of economics research as opposed to clinical research. They missed a pretty fundamental gap between theory and reality. And I'm just going to let you know what the methods of this study were, and I think that you'll probably pick up immediately on what the underlying problem was. So this was an observational cohort study of a sample of Medicare claims data. Let me say that again. A sample of Medicare claims data. They looked at non-rural counties between January of 2009 and October of 2011, and they split them into two groups. I'm sorry, now this is only patients in cardiac arrest. They also did this exact same thing in medical emergencies with the same results. But in this case, this is just cardiac arrest. So all patients with Medicare claims data, in other words, someone submitted a claim to Medicare on behalf of a patient in cardiac arrest. And they split that group up into ALS or BLS based on the Medicare billing level. Based on the Medicare billing level. I think that's really important. Medicare billing level is not whether ALS or BLS procedures were actually done. It's what got billed. So, what did they find? 31,000 patients had ALS billed for that cardiac arrest. 1,600 had BLS. Huge difference in numbers. They found that BLS CPR only had 13, and this is all comers, by the way, everybody that cardiac resuscitation is attempted on. So not just VF. Survival to hospital discharge was 13% with BLS versus 9.2% with ALS. They found survival to hospital discharge 8% with BLS versus 5.4% with ALS. And they did this kind of weird. The percentage of patients with a poor neurologic outcome. So they flipped what we normally do, which is say good neurologic outcome. They flipped it on its head. So in this case, lower is better. Patients that got treated or billed for BLS service only had a poor neurologic function 22% of the time, whereas patients who were billed for ALS service had a poor neurologic outcome 45% of the time. So, what are we to make of this? Well, first off, these conclusions could absolutely be true. It could be that BLS is better than ALS in cardiac arrest. Could be. This paper doesn't prove it. This paper doesn't come close to proving it. Now, the one aside I'll tell you here is if you find yourself with a nasty, nasty case of insomnia, baby, this is the paper for you. This thing, it will so put you to sleep. This is a very, very dense statistical paper. They did so many statistical corrections to attempt to correct for the fact that they were looking at wildly, wildly different populations, wildly different numbers, and what is inherently a bad indicator of what was done. So lots of dense statistics. And my take is that if you have to do that many statistics to control for differences, then there's a fundamental problem with the question you're asking. You need to ask it in a different way. This paper did not look at what was actually done, just what was billed. Using billing as a surrogate marker for care delivered, I think, is just asking for problems. So I'm not going to jump too much in here, but this paper is out in public. People know about it, and you could very easily be asked about it. All right. Back to something that I may not like the conclusions on and I may scratch my head about, but this paper as opposed to that last one. This one was actually very well done. So this is a ROC trial. Again, there's the Research Outcomes Consortium. And what they're looking at was continuous CPR, continuous compressions, versus interrupted compressions. So I'll tell you a little bit about the study and then tell you more about the interventions. So first off, this was a cluster randomized crossover trial, and that means that of the 114 agencies who were participating in this trial, some of them would be doing continuous compressions while others would be doing interrupted compressions. And then after a 6-month block of time, they would switch to whichever one they were not using. And they did this in the correct way. They understood that it's difficult to get an entire system going from one approach to CPR to another. So they would give you a 6-month phase-in block time in between in which they weren't calculating the data. Those were random assignments. So the two groups of patients, those who got continuous CPR and those who had interrupted CPR, were randomized. And the reason we do random assignments is to control for all of those other variables. And it turns out they actually looked at all the two groups on a lot of different variables, and they were the same. So really the only difference between these two groups is whether you got continuous versus interrupted compressions. All right, so the population, these were adults who had non-traumatic cardiac arrest, and their definition of the intervention. So continuous compressions was you would get there and do compressions at 100 times a minute, and you would not stop to ventilate. You would, however, ventilate. So they did not do the full-on MICR, Bobro approach to CPR where you just don't do any active ventilations for 6 minutes. They did compressions, so you have two people going to town on the chest doing very high performance CPR and somebody else attempting a synchronous BVM ventilation during compressions at a rate of 10 per minute. So that's continuous compressions, and it's not really what a lot of us think about as continuous compressions. Now, the control group had interrupted compressions, and they did a 30-to-2 ratio, 30 compressions, pause for no more than 5 seconds while you put 2 ventilations in. Now, they really tried to control the quality of CPR, so they looked at the CPR performance metrics from all of these agencies to make sure that the quality of the CPR was being done well and that they were the continuous was truly continuous and interrupted was truly interrupted. Now, and they did a pretty good job. There's pretty tight control there. So the other thing they did, and this is important for us to understand, is they did the difference between these two groups was in place for the first 6 minutes. They didn't intubate the patient for the first 6 minutes. After that, they would go ahead and do whatever type of advanced airway that they do, and then they would switch to continuous compressions. So the interventional difference here was in the first 6 minutes. So in both groups, they deferred either intubation or a supraglottic blind insertion airway device for those 6 minutes. All right, so what did they find? First off, we know that response time in cardiac arrest actually matters, but only if your response time is under 4 minutes. Only 20% of the responses in either group were actually under 4 minutes. That really, because it was the same in both groups, doesn't have a difference in the outcome, but it does tell us how hard that standard is to meet. Response times are a really, really difficult standard if we want to focus on the response times that matter. The response times for ALS in both groups averaged 9 minutes. So both groups had the same number of shockable rhythms, or 22% in both groups. And the 56 versus 58% had an intubation attempted. So that's essentially the same number. Interestingly, only 84% were successful in their intubation attempt, and that was the same in both groups. But it gives you an overall success of 84% with intubation during CPR. All right, so what was the difference in outcome? Essentially, there was no difference in survival with either continuous or interrupted. Now, that is not really what I would have expected. I was expecting to see that continuous compressions had a higher survival than interrupted compressions. And that's what most of our literature has been suggesting. The literature that looks at flow rates and looks at compression fractions, we see that it is much better with continuous than it is with interrupted. What this trial said was, well, does that make a difference? And it turns out that in this study it did not. It's a little disappointing, but I think that this group of researchers did a really good job at asking this question. Now, I think, and just to give you some idea of the time frame, the data collection on this was done between June of 2011 and May of 2015. Think back to what was going on in 2011, and then doing this trial is going to take probably, I'm going to be nice here and say probably 2 years to just plan and get in place. So they had to have the intervention locked down probably by 2009, 2010. We know a lot more about the approach, the MICR approach to CPR now than we did then. So the question we'd like to have answered now is not the question that they answered, but I don't want to beat these researchers up because of it. So why is it? Why do we think that we see no change in survival with continuous versus interrupted compressions? Well, one potential is the compression fraction in both groups was very, very high. The compression fraction in the interrupted CPR was 0.82. 82% of the time, they were actually having hands on chest doing compressions. That is very, very high. The continuous compression group only got up to 90%. So there's a difference, but it's not that huge of a difference. So we would expect, perhaps the reason that we're thinking compression-only CPR is better than interrupted compressions is because it gives us a higher compression fraction. And in this study, even though the continuous compression fraction, or continuous compressions had a good fraction, it wasn't that much better than an unbelievably good interrupted compression fraction. Number two, in the continuous compression fraction, or the continuous compression group, they were trying to do these asynchronous BVM ventilations. Now, I'll admit, I don't have a whole lot of experience trying to bag with compressions because I've always taken it as a given that that was a bad idea and that you're not going to get much air in. So I just am not sure what to make of that. So bottom line is that this was another well-done study, but it shows that there is no survival benefit to doing what we thought was a good thing. Again, I think there may be some reasons for that, though. All right, next up is our last paper. This is intravenous subdissociative dose ketamine versus morphine for analgesia in the emergency department, a randomized controlled trial. So what was this paper looking at? Well, it really wanted to compare in a good research methodology fashion whether you can just use small doses of ketamine for analgesia and get effects that are as good or better than morphine. Now, for the most part, what they found is it was as good as morphine. So, equal analgesic effectiveness. Let's talk about the study itself. So this was a prospective, double-blind, randomized controlled trial. This is as good as research gets. They put a lot of effort into this and really did a neat job. The way they would do this, what this means is that the physician giving the drug, the nurse, the physician ordering the drug, the nurse pushing the drug, and the patient, none of them know what drug they're getting. All of these patients were prospectively consented, so they were able to do this. So how'd they do that? They had the pharmacy staff came in and they would randomly assign patients to either the morphine group or the ketamine group. They would do that by a computer ahead of time that would randomly say, patient comes in, they get this drug. Next patient comes in, they get this drug. The pharmacy would draw the drug up based on how much the patient weighed. They would put it in a blinded syringe so that you can't tell, and they would hand it to someone who would then who would not know what was in it. They would then go take it to the nurse who didn't know what they were giving. So that's the way it was blinded. What were the doses of drug? Typically, the way this works is when people do this poorly, is they'll use a subtherapeutic dose of the drug they don't want to see work and a therapeutic dose of the drug they want to see work. So, in other words, they'd use like a normal dose, 0.2, 0.3 milligrams of ketamine, and only 2 milligrams of morphine. But they actually did this well. They used 0.3 milligrams per kilogram of ketamine, and they compared that to 0.1 milligrams per kilogram of morphine. So those are both real doses. If they needed, that was the drug they would give, and then if they needed a rescue, in other words, that didn't control their pain, they needed more pain control, they would give them fentanyl as the rescue, and they would use, again, real doses, so 1 microgram per kilogram of fentanyl. So first dose, ketamine or morphine, both in real doses. So their primary outcome was their pain scale at 30 minutes. They'd get a baseline pain scale and then a pain scale every 15 minutes. And the primary outcome here was pain scale at 30 minutes. Secondary outcome was whether they needed rescue analgesia at 30 or 60 minutes. 30 minutes they'd go in, sir, do you still hurt? Do you need some more drugs? Yes, then they'd give them the drug. What was the population they were studying? It was age somewhere between 18 and 55 years old, and it was patients with abdominal, flank, or musculoskeletal pain. They eliminated all the potential booger bearers, things like head injuries or interocular pressure, things like that. Not that we are particularly worried that ketamine would hurt those people, but you have to be really, really, really careful and very conservative to get the IRB to sign off on doing a study. So that's the reason they excluded them. And again, they used written consent. So they measured pain scores, and what they found at baseline is that the patients getting ketamine, their average pain score was 8.6 versus 8.5 with morphine. So that's essentially the same thing. At 15 minutes, the pain score with ketamine was 3.2 versus 4.2 with morphine. Now that is not a statistical difference. At 30 minutes, their primary outcome, pain was 4.1 with ketamine versus 3.9 with morphine. Again, not a statistical difference. And at 60 minutes, there was a statistical difference. Now, this was not their primary outcome, but by 60 minutes, pain control was better with morphine than it was with ketamine, which kind of makes sense because morphine just lasts longer. So they also looked at time or the percent of patients at a given time who had complete resolution of pain. Nope, feel fine, don't need any more pain medicine, I'm living the dream. At 15 minutes, 20% of patients with ketamine had complete resolution versus only 6% with morphine, and that was statistically significant. So at 15 minutes, you have a higher percent of patients who have complete resolution of their pain with ketamine than you do with morphine. That difference, however, is gone by 30 minutes. So we see early on that there is better pain control with ketamine, but then you lose that with additional time. So the number of side effects, adverse events, was statistically the same with both. There was an increased number of patients with disorientation or mood changes is the way they describe that. I'm guessing what that means is dysphoria. More disorientation versus mood changes with the ketamine than the morphine. So the bottom line, the conclusion here is that these provide equal analgesic effectiveness. If for whatever reason you're not able to give narcotics, like say the DEA has become a significant pain in your butt and you no longer have the ability to give morphine on standing order, which is what the DEA may be trying to tell us, and you just can't do anything else, well, you do have another effective alternative in ketamine. So that is, those are our 10 papers. I think there was some pretty interesting stuff in here. We know ketamine is good. We know ketamine is good for combative patients. We know ketamine is good for analgesia. We know delayed sequence intubation is good. We don't know anything about whether BLS is any better than ALS, although we do know we have a paper that's going to make our lives difficult. We know Versed is better than Valium for seizures. We know having firefighters drink Slurpees can decrease their core temperature and perhaps allow them to function better for a longer period of time. We know that transmitting 12 leads does not significantly decrease false positive activations in LA County, which I think is about all we can really say for that paper. We know that intubating patients, trauma patients, increases their likelihood for getting pneumonia, but it doesn't, intubating them in the field doesn't increase it any more than intubating them in the emergency department. And then we also know from Anchorage that if you're going to use the Lucas and want to maintain good compression fractions and slow interruptions, you have to choreograph it, and you have to do it as a team sport. You have to figure out how you're going to apply that. All right, well, that is it. If y'all have any questions, my email address is jjarvis@wilco.org, and I'd be happy to answer questions about it. I think this is some fascinating research, and I think it is something that probably really just needs to make us think more about what we're doing, and I hope that this lecture has helped you think more about what our practice is. Thanks a lot, y'all. I appreciate you bearing with me.